So good afternoon and maybe good morning to many of you. It's great to see everybody, and we're certainly so pleased to have everyone joining us today for this next installment of our Healthy Moms, Strong Babies webinar series that we launched actually now several weeks ago. And we're really pleased and excited about this episode, which I think will be so informative to so many people. This episode is a continuation of a conversation we started a little while ago. What we'll be talking about today is really confronting the hard truths of how systemic racism affects moms and babies, and this is part 2, and who knows, we may end up having to do, and we probably should be doing a part 3 and part 4 so we can continue the conversation even after today. But I certainly want to thank you all for joining today, and I'm really so excited about the panelists that we have joining us, who are just amazing and are going to bring amazing insights to us. I think part of the conversation we want to continue today is really, one, better understanding the inequities that exist in maternal and infant health and understanding how we got to this point. I think a lot of us don't really have a good understanding of how the history of this country has actually contributed to the place that we're in today with respect to so many inequities between Black and brown moms, especially African American moms and babies, and white moms and babies. And so this conversation, I hope, will both help all of us have a better understanding of this, but also help have us have a better understanding of what we can do going forward. If you missed the first part of the conversation, you can certainly go back to the March Moms Facebook page and see the first part of this conversation. And especially if you're joining today, it'll probably be good to have that context at some point. We'd also like to thank Merck for Mothers for generous support, helping us to bring this content and continue this conversation. They've been a valuable and important partner to the March of Dimes, and we're grateful for their support. One of the things that I think we all need to acknowledge, and again, we've said this time and time again, before this global health crisis of a pandemic of COVID-19 hit all of us, we were already facing a health crisis with respect to moms and babies in this country. This isn't really new for us. In fact, the US remains the most dangerous developed nation in the world in which to give birth, which is shocking. It's absolutely shocking to actually not only say that, but to actually know that that is true. And many of these issues in terms of the inequities that we're facing with Black and brown moms who are dying at much higher rates than white mothers due to pregnancy and childbirth, babies of color who are still dying at higher rates than white babies. We've been dealing with these issues since the time of slavery. And when you look at the period of our history over 400 years since slavery, we have never really tackled this issue of what it really looks like to provide adequate, safe, affordable, and high quality healthcare to all people, especially the descendants of former slaves. And that's our reality as we are here in 2020. And it's only made worse now because we're now dealing with this pandemic. And even though we've heard these stories from really high visibility people like Beyonce and Serena, we appreciate them telling their stories about what they experienced. And it's shocking that women, with their stature and their access to resources would have to face some of the challenges of near-death experiences because of due to giving birth. We know that this happens on a daily basis to everyday women who deserve to be here with us and are not. And for too many babies who've suffered a premature birth or who have died before their first birthday, and that outcome did not need to exist. And so what we know is that influence and education and even celebrity status don't shield women of color from some of these outcomes. We know that everyday people are suffering from treatment that they should not have to experience on a daily basis. And certainly during the pandemic, we want to continue to raise the flag that this is a challenge in this country, and we cannot lessen our focus on this, even though we're in the midst of a COVID-19 pandemic, that we need to make sure that moms and babies are protected, even during this most stressful time. And I think all of the issues around inequity in this country have been brought to a new height with all of the recent issues that we've been experiencing with respect to deaths, even beyond the realm of maternal and infant health, with George Floyd, Breonna Taylor, so many others that we're facing. And it is really time and sort of over time, I think, that we have a real honest conversation about what we can do to address the inequity that we're seeing and reverse it once and for all. So that's what we're going to be talking about today, is this history and the reality of how racism has impacted the healthcare system, has impacted how people of color, African American people, and other brown people in this country live, and why we live in these conditions that we live in. We're also going to be talking about the weathering effect of chronic stress and what kind of profound impact that has on the health of Black women and how that's persisted over generations, again, since the beginning of slavery in this country. The role that bias has in our healthcare delivery system, and how that impacts pregnancy and childbirth, and certainly what true equity and justice looks like in this country, and what actions we can take to affect that change. So again, thanks for joining us. Look forward to the conversation. I'm going to introduce our panelists today. Again, really pleased to have them with us. I've had a chance to get to know some of them even more than others, but certainly been glad to be introduced and get to know some of our panelists as a result of this conversation today. First, want to introduce Dr. Deidre Cooper Owens, who I did have a chance to meet some months ago, and she blew me away. She is an amazing individual, and I know she's going to talk a little bit about her work in her first book, Medical Bondage: Race, Gender, and the Origins of American Gynecology, which won a 2018 Darlene Clark Hine Book Award. But Dr. Owens is a director of the Humanities and Medicine program and a professor in the history of medicine at the University of Nebraska-Lincoln. And she's also a former fellow of the American College of Obstetrics and Gynecology. So Dr. Owens, we're proud to have you with us. Next, to introduce her is Dr. Robin Jones. She's a Senior Medical Director of Women's Health at Johnson & Johnson. She is a board-certified OBGYN. She's also an ACOG fellow. She is also an integrative medicine health coach. She's a strong advocate for maternal health, and she's spoken about the impact of societal stressors have on Black moms in our country today. So Dr. Jones, we're so excited to have you. Jacqueline Howard is a reporter for CNN Health. She works on covering the latest in medicine and healthy living. She has been covering the latest news on COVID-19 and racial disparities and doing a fantastic job on that. She's also a member of the National Association of Black Journalists. Jacqueline, we're really excited to have you with us. And last but not least is my really good friend, Charles Johnson, who's an advocate for the health and safety of moms. He's not just an advocate, he is the advocate for the health and safety of moms across this country. If you have not had a chance to get to know Charles, to hear his story, you cannot help but be moved. Charles is a founder of For Care for Moms, which is a nonprofit. And the mission of it is to advocate, educate, and provide support around improved maternal health policies and regulations. But he didn't just start this in a vacuum. He started this because of the passing of his own precious wife, Kira. And I know he's going to share his story. Charles also comes from a strong family in Atlanta, Georgia, of advocates and strong protectors of our civil rights and our human rights. And he is living out this legacy of his family, even after the death of his own wife. So Charles, we're happy to have you join us. We also have a video statement prepared by Congresswoman Lauren Underwood. She could not be with us today, but she wanted to provide a brief statement in support, and she is one of our most ardent supporters of maternal health, especially Black maternal health in Congress. So we're going to be pleased to have a message from Congresswoman Lauren Underwood today. I'm going to moderate the session and kind of get us into our discussion today. And I'm going to start with Dr. Owens. I'm going to call her Deidre, so that we can all be on a first name basis here. Deidre, you are an amazing professor, and you have looked at these issues of the historical impact of slavery on women's health, especially as it relates to Black women. Please just level set our conversation today and give us some background on how we got to this point. Talk a little bit about the history of where we've come with respect to Black maternal health and why we find ourselves in the place that we're in today with respect to the inequities that we're experiencing.
Thank you so much, Stacey. If you would allow me just 20 seconds, I know we're going to say her name again, as we should, but I want to dedicate at least my presence in this webinar to Shaisha Washington, who leaves a daughter, Chloe, who leaves a partner, Jawan, and didn't have to. And so I want to dedicate this to her. Now, to get to the historical question, this thing is colonial. And so when people ask me about this, well, how long has this been going on? I'm going to just start with a British colonial project, not even the French, the Spanish, the Dutch, but the British one. And so when we start looking at these colonial laws, British legislators decided that in the colony of Virginia, that was a very lucrative one for them. They would go against a law that had governed their society for over a millennia and create partus sequitur ventrum. And it essentially means that a child inherits the status of the mother. And this wasn't done because white women were having babies or even indigenous women were having babies, but Black mothers who were owned and considered chattel movable property were having babies. So they upend British law to say that if an enslaved woman is pregnant and gives birth, that the child inherits the condition of the mother. And so that's really the first building block of what we call structural racism and anti-Blackness, and it's tied up in gender. And so as we move from the colonial period to the United States becoming a country in the late 18th century, in the 1780s, all of a sudden, you now have the state, which is the federal government, slave owners, insurance companies, medical doctors, medical colleges, all in a synergistic or sharing relationship where they are now not out of the benevolence and goodness of their heart trying to restore Black women's reproductive health, but what they're trying to do is make sure that these enslaved women are healthy enough to perpetuate the system of slavery, because it has now placed the United States by the 19th century as the fourth richest nation in the world, right? And so slavery does that. And so what I often leave audiences with when I give these talks is to think about the ways that these folk were so concentrated on repairing Black reproductive health to perpetuate a labor system based on capital, that in freedom, you don't have the same kind of attention to Black reproductive health for Black women and birthing people.
It's so profound. I mean, I think that's what a lot of people don't realize is how deeply, deeply rooted, you know, these issues are in our systems and our laws, even in the founding of this country, coming even from the roots of it, even before people even got here, right? I mean, looking at British colonial law. Talk about how slavery, because it's so interesting to me that if the labor market, and of course at one point in our history, the greatest asset that existed in this country was the ownership of slaves, right?
Yeah.
To the extent that the economy was really built on slavery and then was deeply invested in the reproductive capability, especially of Black mothers, how is it that if it was, let's say you don't value the human life, you just value the economy of it. How is it that we would still not then be protected in terms of the viability of our lives, our health, our babies? How did we get so far off in terms of the very asset that people wanted to protect was now put so much at risk, and we're still dealing with the generational effects of that?
Right. It's because, I mean, you know, in many ways, you're dealing with something that for a lot of people is hard to wrap their heads around. The enslaved person is object, so a thing that is property and movable, and subject. It's a human being, right? So you can't impregnate a duck or a table or any other kind of movable property, but you can impregnate a human being who is owned. You can force that woman, that mother, to nourish a white child, you know, and literally drain her body of the nourishment needed or nutrients needed to feed her own child, because you are interested in the maintenance of anti-Blackness, right? That's a cornerstone of establishing this kind of labor system, and having people who don't even have access to owning people on board. But beyond that, it's a labor system that is predicated upon people's work, their work, right? The labor that's performed. And so it's really done because the international slave trade ends through the US Constitution in 1807. So by 1808, every US-based slave owner is now trying to increase the natural birth of Black women. What is interesting to me is after slavery ends and we have all of the constitutional amendments that are supposed to give equal rights, as it were in the 19th century, that are supposed to be about democracy, the narrative changes. So now you have free folk who are seen as a financial burden and dependent class. So all of a sudden, these healthy breeding women who are valuable to a system in a country are now considered welfare queens, irresponsible baby mamas who are seen as a drain on society. And so we must not, in fact, perpetuate the reproductive capabilities of these folk. And so at the core of it that has been long lasting is this strain of anti-Blackness. And that's what I'm constantly telling folk. And so when I hear these kinds of asinine arguments about whether systemic racism exists because you can't prove it by science, I'm like, just look at the laws. They're not hidden. They haven't been taught. But my joke is always, I'm trying to tell a history to be told, not necessarily sold, right? I'm trying to tell a history that exists. And that is very easy to pull out from a primary source document, nowadays, even the internet. And so that's really what it was about, the perpetuation of an anti-Blackness that has persisted for centuries.
So once you start to look at a group of people, not as humans, but as things, you have already devalued their lives, and therefore you're not investing in their lives. And then we see the result of that over generations, right? Boy, and one of the things that I think people don't understand, and one of the reasons I appreciate you being on, Deidre, is because we don't know our history.
Yeah.
We are not taught this history in our schools. We're not given this insight. This is the history of America, and we have to confront these hard realities if we're going to deal with them honestly, right? So thank you. We'll come back to you. Dr. Jones, Robin, thanks for joining. You have spoken extensively about the impact of chronic stress on Black women. We have another partner and someone you probably know, Fleta Mass-Jackson, who's done an extensive amount of research on this as well, who's amazing. And there has been research in this country about this term weathering, and what that really means. And would you just kind of describe a little bit about weathering, and also kind of discuss the way you see systemic racism having an effect on Black women and minority women, other women of color, and their health, and how that's played out in terms of maternal health and infant health as well?
So weathering is a term that may be unfamiliar, but the concept behind it is not. As Black Americans, every time we walk into a room, particularly when we're the only Black person in the room, that becomes stressful for us. Most of us have learned how to handle it. We have other things that may stress us even more. But what happens is it then becomes a chronic stress. Being Black everywhere you go. How are you dressed? How are you speaking? Are you going to answer the question correctly? And especially, I happen to be in a setting in corporate America where it's not uncommon that in a room, I may be the only Black person. And for many of us, that may have been how our education was throughout school, where we were one of a few. So it started as children, where just being Black is a stress. So what does that stress do? Well, for Black women, it's not related to income at all. And that's one of the things that was thought, well, maybe it's women who make less money than others. It's an equal playing field for Black women. And what weathering can do to Black women is decrease our lifespan by almost 8 years. Or think of it as aging us 8 more years, just from the chronic stress of being Black in America. All of us know what stress is, and you know how you feel. It's like that fight or flight. Your gut gets tight, your head hurts, you may start to perspire, your heart beats fast, your breathing gets shallower. Those are all the fight or flight symptoms and signs, and that happens because of a physiologic reaction in your body. So imagine having that all the time at some low level because you're Black in America. We already know that all those hormones and neurotransmitters that go up in that setting are related to chronic disease. It's related to hypertension. It's related to heart disease. It's related to diabetes. All of those which we seem to have a predominance of in our community. So the weathering concept is just that chronic stress, or being presented with that chronic stress of being Black here in the United States, is weathering us. It is physically aging us, physically making us more susceptible to chronic illness. So the other part of being Black in America has to do with just the social determinants of health. And that may be, part of it's going to be economics, but it really is where we grow, where we work, where we live, where we learn, and where we age, and what's happening in that environment with these social determinants of health. It impacts each of us different ways. We may live in more crowded living situations, so a more dense population, and that's important now as we think about COVID-19 and how that's spread. We may be the ones who always have to take public transportation. We may be the ones who have poor water quality or poor air quality. I mean, we all know about Flint. I don't have to go through the Flint story. We may also be the ones that just having those underlying medical conditions has to do with how well or how healthy we can be. We're also less likely to have continuous insurance. So we may have it for a time, we may not have it at all, but we don't have it continuously. So we're not continuously getting regular health care and getting visits. And then there's the whole access issue. You know, some of it's physical access, yes. I mean, those of us that live in cities, we live easy commuting distance to a medical care facility. There are some of us that live in more rural areas where that may not be the case. In either circumstance, the access is not just physical access. It's the access that we don't have because of the lack of trust, because we're not heard.
Right.
We get to those healthcare institutions. We're not able to share in our care. We're not able to share our story because a decision has already been made for us about us the moment they see our face come in the door.
So the
and all of that
of
impacts how healthy or how well we can be.
How well it can be, and it certainly does have an impact even on moms and maternal health outcomes and infant health outcomes. And so we'll come back to that. But thank you for that, Dr. Jones. That was really helpful because it's an important aspect of what it means to be a Black mother in America, and explains a lot about, you know, the impact and the outcomes that we see. I want to turn it to Jacqueline. You know, Jacqueline, can I call you Jackie? I don't know, whatever you prefer. You know, you've been reporting a lot on CNN with respect to COVID-19. I think a lot of us have been tracking a lot of this, the outcomes that we're seeing, the disparate outcomes that we're seeing with respect to the pandemic on Black and Brown communities. Talk briefly about what you're seeing in terms of the spike in cases, the disparities. What have you found out in your reporting, and any insight you have about maternal and infant health and what you're seeing as well with respect to the pandemic?
Yeah, absolutely. I mean, like you said, we're definitely seeing disparities emerge. We're definitely seeing a rise in cases, and as cases rise, that disparity continues to grow, and we're continuing to see cases in younger people. But what is really important here is to remember that this disparity is not new. Like Deidre mentioned, the disparities in health go back years and years and years. And even with H1N1 in the year 2009, there was data out of the state of Illinois that found that Black adults and Hispanics were 2 to 3 times more likely to be hospitalized with H1N1. And we're seeing similar disparities again now in 2020 with COVID-19. So just to put in context, this really isn't new, and it really comes down to the social determinants of health that Dr. Jones mentioned. And so that's important, really, I think, to keep in mind while we watch this pandemic play out on the ground. And because of those disparities, because, you know, this is, again, a repeat of history, we are seeing this impact on moms and babies. And, you know, it comes down to the fact that with dealing with social determinants of health and thinking about the biases that Dr. Jones mentioned, how that really becomes exacerbated in emergency situations. So something that we're seeing on the ground and something that I think will be really interesting to see play out as the pandemic continues is because of the pandemic, we're seeing a rise in the use of telemedicine. So a lot of prenatal care visits are now virtually, and there's a lot of interruptions in prenatal and postpartum care. So as we see telemedicine come in, does that leave room for bias? If as a patient, you can't physically go in to show a concern or health concern to your doctor, and you just have to deal with talking to them on video or on the phone, does that leave room for the bias that Dr. Jones mentioned? So a lot of this is really intertwined, and that's what we're seeing on the ground as cases rise, as the disparity continues to grow. And so it will be really interesting to see, okay, how does this play out moving forward and in the years to come as we see the ripple effects of the pandemic?
And of course, the health inequities for those that have access to telemedicine, and they've got great. There's no digital, barrier for them. It's great if you're a Black and brown woman without access to broadband or high-speed internet. Telemedicine may not have even been an option for you, even during this pandemic. And what does that mean for underserved communities and Black and brown communities? So that's a great point. We have a question from Facebook. I'm going to get to it in just a second, but it actually speaks to the next thing we want to introduce, which is this quick video and message from Representative Underwood. And then I want to introduce Charles. But as I mentioned earlier, Congresswoman Lauren Underwood is the chair of the Black Maternal Health Caucus. She represents the 14th District of Illinois, and she has been a great leader and leading on the legislation by this caucus of something called Momnibus, which I think she's going to talk about, which is a series of bills designed to address maternal health equity. So let's just see Lauren Underwood.
Hi, everybody. I'm so glad to join you today. I want to thank Stacey Stewart and the March of Dimes team for hosting this event and for your ongoing work for moms and babies. Stacey, thank you for all that you do. The past months have been profoundly difficult for our nation and for Black communities in particular. Black Americans have been killed by police officers. Black Americans are dying at disproportionate rates due to COVID-19. And as all of us know, Black moms continue to lose their lives in the midst of our nation's ongoing maternal health crisis. We know that unequal access to care is a cause of racial gaps and maternal health outcomes, and it was also identified as a driver of COVID-19 disparities by the National Institute of Minority Health and Health Disparities. We also know that racial and ethnic minority populations are more likely to suffer from an underlying comorbidity like diabetes, cardiovascular disease, or asthma, conditions that are oftentimes driven by social determinants of health like food insecurity and environmental threats. We will need targeted interventions informed by comprehensive data collection that's stratified by relevant demographic characteristics, including not only age, sex, and geographic location, but also race, ethnicity, and pregnancy status. I'm grateful to the March of Dimes for their partnership on the bipartisan letter that I led with Congressman John Lewis, signed by 62 members of the House, requesting that Secretary Azar take all available steps to adequately understand the unique risks and effects of COVID-19 during and after pregnancy. That's why it's so significant that the Patient Protection and Affordable Care Enhancement Act, which we passed out of the House of Representatives on June 29th, included a requirement that every state extend postpartum Medicaid coverage to 1 full year after delivery. March of Dimes has been an invaluable partner in developing these bills, and they're now even more important in the face of this pandemic. For example, the Moms Matter Act, which was sponsored by Congressman Joe Kennedy and has 3 Republican co-sponsors, make investments in maternal, mental, and behavioral health. The Moms Matter Act makes critical investments to address maternal mental health disorders with a particular focus on the challenges facing Black mothers, expanding access to supports that pregnant and postpartum individuals will need during this public health emergency and beyond. Since the first case of COVID-19 in the United States, more than 1 million babies have been born. As we continue to battle this pandemic, moms will continue to give birth, so we don't have any time to wait. Now's our moment to advance legislation like the Momnibus and the 12-month postpartum Medicaid coverage. Please Reach out to your members of Congress, spread the word on social media, and continue to host important events like this one. We can't stop until we pass the policies that will ensure that moms and babies can access the care, support, and social services they need and deserve.
Wow. We're really blessed to have her in Congress, I think. She has been amazing, and what she has done, and as she mentioned, with a lot of supporters. She actually mentioned Congressman John Lewis, and I want to take a moment for us to all just send some prayers up for him as well, who's always been a fighter for what's right, and is fighting for his own life right now. But thank him and thank Lauren Underwood for her tremendous leadership, Alma Adams, Robin Kelly, so many other great members of Congress who've just been phenomenal in this fight for maternal health. One of the folks that has been at Congresswoman Underwood's side in the development of Omnibus has been Charles, and I think the country is fortunate to have Charles and his passion and the time that he's invested in this work. To not only tell his personal story, but to actually get us to a place of policy change, which is going to be so critical if we're going to make things better for moms and babies in this country. Charles, thanks for joining us. And I know a lot of people have heard your very heartbreaking story. For those who haven't, if you could just share briefly that story and then tell us a little bit about what you see going forward in terms of your work and the agenda that we need to work on.
Absolutely. First of all, Stacey, thank you so much for having me. Thank you for everything that you do, your amazing team at the March of Dimes. And just briefly to the three dynamic sisters, four, including you, Stacey, that I'm sharing this platform with. For me, in my journey as an advocate, I'm always constantly trying to learn. So thank you so much, Deidre, for the work that you do, for your voice and what it has meant for so long. And thank you, Robin, Dr. Jones, for everything that you do and just bringing this attention and continuing to fight and speak up for our mothers. And so for me, I will share with you all the very condensed version of what has gotten me to this place in my life. So I was fortunate enough to meet a woman that absolutely changed my life. When we talk about my wife, Kira, we're talking about sunshine personified, right? We're talking about a woman that raced cars, who ran marathons, who had her pilot's license, who was absolutely crazy in the best way. She was a skydiver. And so, and really, like I say all the time, really honestly, quite honestly, far out of my league. But, I always wanted to be a dad. We welcomed our first son in 2014. We always talked about having back-to-back boys. So we were over the moon. We found we were welcoming our second son, Langston, in April of 2016. So on April 12th of 2016, at our doctor's recommendation, we walked into Cedars-Sinai Hospital for what was expected to be a routine scheduled C-section and what we really expected to be the happiest day of our lives. Langston, our new son, was born perfectly healthy, 10 fingers, 10 toes, very handsome, looking just like his dad, right? I joke a lot. And, shortly after that, they take us back to recovery. And as we're in recovery, Kira's resting and Langston's resting. I look down and I begin to see blood coming from Kira's catheter at her bedside. And this is around 4 o'clock in the afternoon. So I bring it to the attention of the doctors and nurses at Cedars. They come in, they assess Kira, they order tests, including a CT scan that was supposed to perform stat. Now keep in mind, this is around 4 o'clock. Blood work comes back abnormal. They do a ultrasound. They can see that there's fluid beginning to accumulate in her abdomen. So there's very clear signs very early on that Kira is hemorrhaging significantly internally. But 5 o'clock comes, still no CT scan. 6 o'clock comes, no CT scan. 7 o'clock, 8 o'clock. We're begging, we're pleading for the doctors and the nurses at Cedars-Sinai to take action. And they're just saying, oh, it's coming, it's coming, it's coming, it's coming. 9 o'clock, no CT scan. Around 9 o'clock, I finally pulled the nurse to the side and grabbed her by both of her hands. I looked in her eyes. I said, please help us. My wife isn't looking good. They promised they were going to take her back for a CT scan hours ago. They promised that they said they might take her back for surgery and we can't get any answers. Please help us. And the woman looked me right in my eyes and she said, sir, your wife just isn't a priority right now. Right. And I'm still haunted by those words. And 9 o'clock comes, 10 o'clock comes, 11 o'clock. It wasn't until after midnight, after Kira had been allowed to bleed internally for more than 10 hours, while she had been allowed to suffer unnecessarily for 10 hours, while we had begged and pleaded with the staff to take action for more than 10 hours, that they finally took my wife back to surgery. And when they took Kira back to surgery, they wheeled her through those set of double doors to the operating room. That was the last time I saw my wife alive. When they took her back into surgery, they opened her up, and there were 3.5 liters of blood in her abdomen, and her heart stopped immediately. And so for me, and I'm always very transparent, sometimes even to my own fault, to my own detriment. But like I think a lot of Americans, I really believed that what happened to Kira was an anomaly. But then I discovered when I began to do research for myself that we are, in what we all know sitting on this call today, that we are in the midst of a maternal mortality crisis. Not only that is shameful domestically, but it's shameful on a global scale. And while there's nothing that I can do to bring Kira back, the highest honor that I can pay my wife is to do everything I can to make sure I send other mothers home with their precious babies.
It's hard for me to, I don't know how many times I've heard you tell that story, Charles, and I feel like it's new again every time I hear it, and painful every time that we have to think about it, but we have to hear it, because it is not only painful for one individual family, the Johnson family. We think about the fact that anywhere from 700 to 900 women die as a result of pregnancy every year, that Black women are 3 to 4 times more likely to die as a result of pregnancy and childbirth. It just is shocking and appalling and completely unacceptable. And Charles, tell us a little bit about the policy changes you've been working on and why the Momnibus has been such an important part of that, and how you see change really going from here.
Right. So this work is never easy, but we have so much work to do, but I'm proud of what we've been able to accomplish. And when we think about this contextually, this is a topic when we talk about maternal mortality, and specifically how maternal mortality disproportionately affects African American women. Oh, the cat showed up.
No, I love it. It's great.
Look, you want
we
to
needed that.
I needed that. So
yeah, we all needed that.
So need all that. So the first thing that I'm extremely proud of is able to work along with congressional leaders, as well as my good friend Stacy, to pass the Preventing Maternal Deaths Act, which we passed successfully in 2018. It was the first ever piece of federal legislation designed to prevent mothers from dying in childbirth. It was a important first step, but it was just that, a first step to making sure that but a big step, first and foremost, making sure that we had a bipartisan effort and the federal government recognized that this is an issue and, invested funds and invested resources to try and turn this around. But it was just a first step. And as you heard Congresswoman Underwood speak about the Momnibus. So the Momnibus is something I'm tremendously proud of. The Momnibus is a package of 11 comprehensive bills, not 1, not 2, not 3, not 5, but 11 comprehensive bills, all addressing the maternal mortality crisis, and specifically how this maternal mortality crisis is affecting African-American women and women of color. It does everything from specifically address the needs of our service women, right? It provides additional resources for mental health. It provides additional resources to explore how we can expand using technology, like Jacqueline mentioned, telemedicine and other technological advancements to help prevent this. And it also does wonderful things like fund Black women-led community organizations that are specifically doing this in the community. Because the reality of the situation is it can't just take policy change. It can't just take hospital reform. It can't just take accountability from doctors. It has to be also very important. We have to have input and engagement from the community, from the men and women on the ground who are working hand in hand with these with these women and these families in the communities, and they have to be funded, and they have to be funded properly in order to do their jobs. Another thing that it does is it makes sure we're going to make sure we invest in making sure that we have representation. I have to take a minute and take personal privilege. We talk about representation, how fortunate we are to have a Black woman leading this organization right now, because the reality of the situation is this conversation would not be being had on a weekly basis, addressing this head on, if we didn't have a Stacey Stewart sitting at the helm of one of the largest nonprofits in our country, right? So representation matters. It matters in the boardroom. It matters in the emergency room. It matters in the delivery room. And so this legislation is going to address that as well. So please, wherever you are, make sure that you reach out to your local representative, your congressman or man or woman, and ask that they support the Black Maternal Health Omnibus.
And let me tell you something. This is it's all about us working together. I mean, you know, when I look at the change that has been made so far, and Charles, you made a good point. The Preventing Maternal Deaths Act was just a big first step. But we had Republican support and Democratic support. I mean, it was truly bipartisan. And in this day and age, well, we know how hard it is to get anything done on a bipartisan basis. It was actually shocking that, you know, we got the kind of bipartisan support. I think we're all grateful for that. But we got to do much more. And the Omnibus bill and set of bills is really quite important in that.
Can I touch on something, Stacey,
yeah,
real quick?
Please, go ahead. Sure.
One of the things I think that we've been able to do, and we have to continue to do when we talk about this issue of maternal mortality, is this is not a women's issue. This is not a Black issue. This is a human rights issue. And we talk about this in terms of, in terms that our elected officials can understand, is that when we talk about your constituents, there's only two types of people in this country. Either you are a mama or you have one. So this is something that is uniquely bipartisan, and that everybody should be able to be supportive of, regardless of your Republican, Democrat, whoever you are. What is it? What's Kanye's thing? Don't even get me started.
Right.
Whatever, for the birthday party, it doesn't matter. You should go to support
right.
this.
Right. Yeah, Kanye's always an interesting topic to bring up, right?
That's something, you know, about maternal
Please.
mortality, and there's also the issue of morbidity. So 60% of the women who die, those deaths are preventable. As you heard Charles saying what happened with his wife. And that Momnibus Act, of which Johnson & Johnson is the only corporation in the United States that is a sponsor also for the Momnibus Act, is so important, as well as Medicaid expansion in every single state. Most of the states only cover postpartum care through Medicaid for 60 days. Well, maternity mortality extends for 365 days after a birth. So it is so important that we have Medicaid expansion in every state, and that Momnibus, with the 11 bills that are in it, get moved to the next phase so that they can be passed and become law in this country.
Absolutely.
I want to continue with that. And Deirdre and Jacqueline, I think it is important to say, what are the things that we need to do to actually turn the tide? I mean, obviously we're talking about a lot of policy change. Are there other things that you think this country needs to do if we're going to really fully address these issues around maternal and infant health, especially in Black and brown communities?
Yeah.
Just having the conversation, that, as Charles mentioned, having the conversation is important. Also, you know, when Dr. Jones mentioned Medicaid expansion in March, I remember covering this story. There was new data showing that, I have it here, from 2006 to 2017, states that expanded Medicaid were associated with lower rates of maternal death by 7 deaths per 100,000 births. So the states that expanded Medicaid saw a reduction in deaths by 7 compared with states that didn't, and that's per 100,000 births. So, you know, having the data, having the conversations, I feel like is important. And then being on the ground, the first thing, you know, you tend to hear is that a lot of women just don't feel heard. They speak up, they don't feel heard. And, you know, that seems to be the common thread in every case, every story that I've covered. And it kind of seems to be the beginning of what needs to change.
Yeah. For me, thank you. I think I can, you know, I'm going to echo what has been said by so many of us during this conversation, it really is about listening and not during the moment of a crisis. So what I've noticed as a professor, I'm a professor who teaches students about the history of race and racism. And oftentimes, as a person housed in this body, I will get, even in classes called Slavery in the US, Race, Gender, and Science in Early America. Why is this class only about Black people? Because this country has had Black people since its inception. But almost every time something like this happens, so whether it's a COVID-19 moment that we link with race and racism, if it's a George Floyd or Breonna Taylor moment, I always get emails from students, you know, everything that you said in the class, now it's making sense. So I often say to our white Americans, and I'm being very specific here, stop raising your children to be anti-Black. And that's not me using hyperbole. That's not me being confrontational or provocative. That's me saying I have quantitative data that shows in the healthcare industry, in medical schools, people have anti-Black ideas. So if you listen to what Black folk are saying and folk who have an expertise in this field, you'll find that what we're saying is not, it's not anything new. It's what Black folk have been saying for centuries, and white folk committed to the idea of equity. So for instance, not having outdated ideas in the belief that Black people don't experience pain, or Black women have an easier time during childbirth, or that Black people are somehow susceptible to being, using narcotics or alcohol at greater numbers than everybody else, or that we're walking pathologies. I can literally open up medical textbooks and journals from the 18th century, the 19th century, the 20th century during the era of Jim Crow, and find belief systems that match those of 21st century white medical students in elite institutions like the University of Virginia, University of Chicago, Harvard University, and we can even go across the pond into England and Italy and France. So number one, we have to be able to dismantle anti-Blackness as a buy-in in this society. I think that's important. We also have to continue to enable people to do the kind of on-the-ground work that reproductive justice and birthing justice folk have been doing for centuries. And that comes out of the bosom of Black women who have rallied around this for decades in this country, and also Black organizations who prioritize Black mothers and Black children and Black families. So whether it's the Black Panthers when they did the free clinics and the sickle cell testing and all of those kinds of things, mutual aid societies that we see have arisen out of this COVID-19 moment to continue to allow space. And then I think to have these kinds of integrative partnerships. So right here, we have activists and journalists and medical doctors and the president of an organization and a scholar, right, who writes about, I always have traffic in dead bodies, but, the political resonance still remains. The fact that we are in partnership to impart this kind of knowledge and to tell folk about these things that might escape them because it's not necessarily mainstream in the ways that it needs to be. So for me, it is really about partnership. It is about the dismantling of anti-Black racism. It is about listening to people and not blaming patients for social determinants that really reveal quite starkly and transparently the ways in which inequity and inequality have been stitched into the fabric of this nation.
That's so beautifully said. And, it reminds me of my daughter's 7th grade US history teacher who wrote us before school started and said, in order for us to learn US history, our kids are not going to be able to learn this. And she goes to a predominantly white institution, by the way. Our kids are not going to be able to learn this unless and until they learn first about slavery. So the first thing we're going to do is they watched a movie and studied slavery and the impact of slavery and how it helped form and shape the US Constitution and every part of the beginning of this country. And that was the framing and the lens through which those kids in those classes learned about the history of this country. And I thought it was incredibly powerful. And then today he's one of my favorite teachers. But to your point, Dr. Owens, we do not teach people. We don't teach none of this is taught in our schools in the way that it should. And it starts early in life, and it goes all the way through medical school, as you mentioned, which is a huge problem. We do have a couple questions on Facebook. I want to ask you this question that came. And by the way, if there are other questions on Facebook, please don't hesitate to put them in the chat box, because we do see them. Are you finding Black maternal mortality and morbidity rates are lower in predominantly Black healthcare institutions? Robin, do you want to start with that, or Deirdre?
Yeah, I don't think that's the case. And a lot of it though is because even though it's a predominant, and I'm assuming when you say predominantly Black institutions, you're referencing a hospital or healthcare facility where the caregivers are Black mainly. So that should be the case, and sometimes it may be, but that's not a guarantee. Yes, my face looks like yours, and I'm coming from a place where I'm going to understand where you're coming from, or I should. But let's realize the way we're all trained, even as Black physicians, we are trained in a system where you almost go along to get along, unfortunately. I mean, there are some things that we can do one-on-one with our patients, and certainly once we're out in practice, then should be a whole new ball game. But in the training institutions, you should always expect more, but you may not get it. A perfect example, I trained in an inner city hospital, and every little Black girl that came in there that needed a pelvic exam got a pelvic exam, but not just one, she got several. And I'm sure Dr. Owens, you may have that recollection from your training too. I mean, how many pelvic exams do you do on a young Black girl? Young Black girls come in with pelvic pain, right away they have an infection. They don't have something called endometriosis, which has nothing to do with infection or your past sexual history. But because we are Black women, Black girls, and we have this supposed hypersexuality, we're probably more likely to have an infection than another type of condition that could cause the same kind of persistent chronic pain. So it's those kinds of things shouldn't happen, and being in a Black institution should be better. And most of the time it probably isn't. But it isn't always. I think what I really like to have everyone advocate for is your own health education or health literacy, educating yourself. So you are learning by reading. Yes, the internet's full of stuff. There are books you can read. If you go into healthcare facilities, they have brochures, pamphlets, but you need to educate yourself before you go into any kind of healthcare facility. Before you walk into a doctor's office, you need to know as much as you can about your body, yourself. It all fits into that mantra of self-care. Because if we're not taking care of ourselves, no one else is going to do that. And we start with that premise. That gives us the ammunition to then fight for the policy change, because we know what we deserve and what we should have when we know more ourselves.
And Deirdre Shasia, you mentioned earlier, who 26-year-old Black woman in Brooklyn who just passed away after giving birth, was in what I would consider, I don't know if we would consider that a predominantly Black healthcare institution, but I think talk about the issue of, my father was a physician. I know that my dad and most of his patients were African-American. I know that my father was invested personally in the healthcare of his patients, and for that they benefited, right? But in some hospitals that serve predominantly Black patients, where the doctors and nurses may be predominantly of color themselves, those aren't always the best resource hospitals either, and therefore are not able to have the resources to deliver the best care. And that's a problem too, Deirdre. I mean, wouldn't you say that?
Oh yeah, I definitely say that. And to kind of just for briefly to go back to that question about the data isn't really available around maternal morbidity rates in predominantly Black hospitals. It's not there. You'll find data on communication styles with Black physicians and patients, but that data isn't available. And so what I'll say to I think Robin's point and yours, Stacey, what I literally posted on social media and had a really positive response, it's a heavy burden, but it is also a gift. And this is what Charles talks about. I am the country's, the numbers, I always say this, I'm the second Black woman in this country who is an endowed professor in the history of medicine. And so because I have this position, there's a certain amount of access and power I have. And so I spoke with a Black OBGYN who literally left the States to become a chief medical officer at Hello Clue, which is a German-based company, who taught me about what Robin so eloquently shared with us, the kinds of stressors Black people have in their lives. They shouldn't, Aisha shouldn't have been 26 and suffering from preeclampsia or high blood pressure. That shouldn't be a reality. She shouldn't have gone to Woodhull Hospital that has a centuries-long history of mistreating patients of color, Black and brown, because it's Brooklyn primarily, and poor people, and their intersections with poverty and the kind of anti-Blackness and anti-Latinx nature of Woodhull and the under-resourcing that goes on. So what I'm advocating, after I found out about the kinds of ways that racism affects our bodies and weathers it, ages it, from Dr. Lene Brayboy, that physician I talked about, who went to Germany essentially to do this kind of work, is that we have to have advocates. And I didn't know that there were things called patient navigators. And she said, if you can get one, don't get one affiliated with a hospital. And so for me, it is now, how do I create that data set along with practitioners on the ground, activists? So how do we do this? And then number two, how do we set up resources for people so that they know what a patient navigator is and how to locate them? So even if it's telemedicine, whether you're in a rural area, I grew up, I went to high school in a predominantly Black county in the low country of South Carolina that has not had a maternity ward since 1990. That's when I graduated high school. So if you have to have a baby, if you have access to a car, you got to go to another county, either Florence, Georgetown, or some other surrounding county just to have a baby. There are no midwives there. There are no doulas there. There's one doctor who accepts Medicaid. Right? And this is the poorest county in the state of South Carolina. That is also the most predominantly Black county in the state of South Carolina. And so for me, setting up a database and a resource system is important. It can't be done overnight, but at least I know I got a little bit of power, and I live in a state where Warren Buffett loves to give money to the University of Nebraska-Lincoln. And I have a title that is named after a retired physician who is a multimillionaire. And so I am able to tap into those resources to be able to help community members in ways that didn't exist before because I'm at the helm of that position. And so for me, I want to be able in a couple of years to answer those questions that say, what's the data? Because the data just doesn't exist, unfortunately.
Right. I just want to add one thing to that data that I thought Deirdre brought out beautifully about the lack of OBGYNs and labor and delivery in this country. 50% of the counties in the United States do not have OBGYNs, 50%. And this is one of the richest countries in the world, and we have obstetricians and gynecologists in at least 50% of the counties in our country.
Yeah. And we did a lot of the research at the March Dimes about that, where we looked at the number of counties. It affects millions of people. Counties where women live, where there's no OBGYN, no certified nurse midwife, no birthing centers. It's tremendous. We're just about out of time. Jacqueline, did you have one other point just to add to that?
Oh, I was going to thank Deidre for mentioning how, we do need the data. And as a journalist, I often tell people the stories in the numbers. Like, we look for those numbers. We look for those data points to really find trends, find stories, and shed light on issues like, maternal mortality, maternal morbidity, and other disparities that we often talk about. So it is important to do that research and really, thank you to March of Dimes and other, groups and institutions who are doing the studies that shed light on the stories that need to be told also.
Absolutely. And we will post, I'm sure this has already been done. If not, there's a whole study that was done showing the impact of on the improvements on maternal health and infant health in those Medicaid expansion states, as you mentioned, Jacqueline. So we'll post that to respond to the question. This has been terrific. I'm sorry we're out of time. I'm already feeling like we're going to need part 3. So we will probably do that. Amazing, amazing. You, each one of you, thank you so much. And as we close this out, I just want to say thank you again to Merck for Mothers for today's webinar. Thanks for all of the resources. Hope we were able to post a lot of things, different resources. But here's a chart that shows some of them. We have some posted on our March of Dimes website if you want to learn more beyond labels. I know each of our institutions have a lot of information. If you want to know more and learn more about the Momnibus bill, please go to that, and please sign up to be an advocate. At the March of Dimes, we have an advocacy network. We'd love to get you to sign up to be a part of that. Information for Care for Moms as well, always really valuable. And I would just say, and this is a shameless plug, but we are so reliant on the public support for all the work that we do at the March of Dimes. So if you would like to continue this kind of content, continue this work, support moms and babies, just would ask you all to consider giving. You can text to give to MOD-GIVE, M-O-D-GIVE, to 51555 and help us continue this work at the March of Dimes. It's so important. Please join us again on July 23rd. We have another webinar. The next one is actually scheduled to talk about the maternal mental health crisis, especially faced by Black mothers. It is Maternal Mental Health Month this month, and we are looking forward to continuing to give space to that issue as well. Again, prayers to Shasia and her family, to John Lewis and his family. And I want to say thank you all so much for being a part of this today. It's so great to be with all of you all, and look forward to seeing you all again. Thank you so much.
Thank you.